So you've made it through pregnancy and you've experienced labor. Now we're to the pushing phase. Let's go over what it would be to experience getting ready to push and deliver your baby. We encourage pushing in the most effective way. Whatever feels good to you as the mom pushing, but also what is helping your baby be born. Oftentimes that's in the bed. You can be squatting on your side, laying on your back. It's whatever is going to help your baby be born and also keep you and baby safe.
It's a really common question, and I am so sad that this is still folklore, I think, or such common lore in the public. At least in our institution, it's absolutely not routine practice. We don't want to do an episiotomy any more than moms want us to cut an episiotomy. I would say that there are some pretty uncommon situations in which cutting an episiotomy becomes really the safest and most expeditious way to deliver the baby. But those are unusual circumstances, and we never recommend or proceed with that procedure unless it's felt to be medically necessary and the safest thing for mom and baby in the circumstance. So some things that would lead us to make that recommendation are changes in the tracing of the baby or the fetal heart rate of the baby that would lead us to believe that a quicker delivery would be the best thing for the mom and the baby's health at that moment in time. Other things that can occasionally lead us to make this recommendation are also a very prolonged pushing phase for mom, which can at times become exhausting and overwhelming, in which case we would also offer or make that recommendation.
You get to hold your baby right away after delivery. Our goal is immediate skin to skin and to not interrupt this time for at least an hour, hour and a half to 2 hours, depending on how much time you need to bond with your baby and establish that first breastfeeding moment. We call this the golden hour for mommy and baby to really bond. The only time this is ever interrupted is if your baby needs help transitioning from that water environment to the air environment. Then we pull baby away for a moment in time to help baby become happy and stable, and then we try to get you guys back together as quickly as possible. We recommend an erythromycin eye drop for the baby to prevent eye infections, a vitamin K injection to help with blood clotting factors, and then another recommendation by the pediatrician is the hepatitis B vaccine. Those are usually the standard medications that will be presented to you and your baby after delivery.
Now are recommending and trying to delay cord clamping for at least 60 seconds after delivery of the baby, assuming that mom and baby are healthy at the time of delivery, which is thankfully the case in the majority of cases.
Our recommendation is to use the Pitocin after delivery to help encourage the placenta to be delivered, which also in turn then reduces the risk for mom to bleed too much and what we view it as hemorrhage.
And Pitocin's been shown to be the most effective medication to decrease the risk of hemorrhage or excessive bleeding after delivery, and this actually avoids a number of additional interventions or the use of additional medications by preventing the occurrence of postpartum hemorrhage. I really emphasize to women that our preference is for vaginal delivery as well, but we have a shared goal in that we both want a healthy mom and a healthy baby to leave the hospital. So we will recommend a cesarean section when we think that it's medically necessary, when we think that it's an intervention that will both be beneficial to the mother and the baby under the circumstance. Additionally, we do know that cesarean section is a major abdominal surgery, and we try and avoid performing major abdominal surgery for anything if we don't feel that there's a medical benefit to it. Do our best in the setting of an operating room with the confines of a sterile procedural setting to try and maintain as much normalcy for the mom as possible. And so that involves the ability in the majority of cases for the partner or support person to come into the operating room with the patient, with the mother, and to be at the bedside while the baby's delivered. We have drapes now that allow us in many cases to actually show you the baby as soon as it's been delivered while the pediatricians are drying the baby off, and we're waiting to cut the umbilical cord for that 60-second period of time that we do in vaginal deliveries as well. And although the baby will go to the warmer with the pediatricians immediately after delivery, as soon as they have done a very brief assessment of baby's well-being, they will bring the baby up to mom for mom and her partner or support person to be able to hold in the delivery room, assuming that mom and baby are doing well, which is the case in most circumstances.
One of our goals is, if appropriate, if you're feeling well and the baby has been delivered and is feeling well too, we could potentially try to start breastfeeding in the operating room. We have a nurse on hand that helps with that as well. Sometimes it's a snuggle and the baby isn't quite ready to nurse right away, but the bonding of skin to skin begins that initiation. And then the actual suckling and this really breastfeeding that everyone imagines of the baby doing the long sucks occurs in the recovery room, but that's well after the long skin to skin as well.
And in cases where mom and baby do end up separated for some period of time, one of our highest priorities is always getting mom and baby back together, whether that is a short delay in the recovery area while we're making sure that mom and any complications that she experienced during the labor course have stabilized and are safe, or whether that's, you know, an assessment of baby by the pediatricians or in the nursery or the NICU. Once those assessments have been completed, we really strive to reunite mom and baby as soon as it is safely possible to do, even when the circumstances of delivery were unexpected.
Their partner can accompany you anywhere that you go. We will be able to help them dress into sterile attire for the operating room, and our hospital staff will also help guide them onto where is appropriate to stand and where to sit and be, but they will be there for you as a support person.
There are some limitations in the operating room. We have to maintain a sterile environment where the surgery is going on, which is separate from where mom and her partner are being supported by the anesthesia team and are not in a sterile area up above the chest and head. But what we've been able to do is we do have the sterile drape now has a clear window in it, so that as soon as baby has been delivered, we're able to open that clear window area so that we can hold the baby up and mom can see her brand newborn baby while we're waiting to cut the cord after that delayed period of delayed cord clamping. So you've now delivered your baby and have gotten to hold and meet this baby that you have been waiting for over a long pregnancy course. So women will recover on our labor and delivery unit for about 1 hour after their delivery and then move to our postpartum unit where they continue to be cared for by a team of doctors and nurses who will help you with the next process of caring for your new baby and your new family, which involves breastfeeding and postpartum care.